Well, this is a tall order. Thank you, first of all, to all three of the presenters. I want to go back just for 1 second to Dr. McInerney to look at this from the perspective. You talked about genetic literacy and the variation and continuity. And I think that we've sort of neglected to look at health literacy in exactly the same frame. We have a need to have that kind of understanding between the two fields, that we are looking for variations, and we have to find those elements of the variations in that ladybug picture that give us some continuity that we can measure. And I think so in hearing these three talks, in the talk about Suzanne, in your talk, one of the questions is how far do we step back? And we're looking at so many things. I'm looking at the fact, I thought there were some just wonderful things in what you presented. But in looking back, and there wasn't a big but there, it was a small, just a question. The factors and consent, it looks as though at the earliest stages, and this is a concern for precision medicine, that at the earliest stages, we use things that have been traditionally seen as proxies for health literacy. And then we measure the health literacy when we get into the research itself. So that and we use some index or some format rather than taking the factors at the very beginning to incorporate health literacy in that process. And I think that's a habit that we've sort of gotten into as a field. I thought that the notion of the literalness of the neighbor, what we call that other person, I wondered if you had looked at your history and then your ideal. Did you ever look at it as looking at yourself as in the perfect circumstances, as a test idea, as opposed to other women who responded? It was just a thought that, do we ever put out that notion of what's the best practice for us individually? And I think that there is, in your process, such a wonderful model for cultural respect. I think that that came across more directly in the description of how you did the preliminary work for this study and how thorough you were about the subpopulations. I thought that was very exciting to see. In Dr. Wilkins' presentation, hooray. First of all, congratulations. This is quite an accomplishment. We're going to be really excited to see what you find. No pressure. But the notion of bidirection and is also a notion of continuous feedback. And, we kind of went back to the human communication research, and David K. Berlow suddenly, was brilliant because he put a second arrow on the relationship between the sender and receiver and said in the 50s, senders are receivers and receivers are senders at the same time. And I think to try and bring into focus that continuous response instead of seeing it as staged and having it be bidirectional, but also continuous, is something that I think would be really exciting to have out of that. I also think that your recognition of what happens with advisory boards or isolated individuals is extremely important in the health literacy environment, because folks who are experts on things sometimes don't have the experiences, and people who are in isolation very often either don't really represent the community but represent their own needs or aspirations, or they are intimidated by the environment. And we see that in a lot of different kinds of advisory relationships. The patient portal idea as a proxy for the interested person, I think, is really important. And you've got different populations there, and you can clarify them. And I think we just are all very excited about seeing what happens with you. Dr. Applebaum, eek. From a health literacy perspective, I didn't, we all use that phrase, but whatever that phrase means. There's a lot of emphasis on what I would say would be CYR, cover your researcher. You know, I did what I was supposed to do. I did legally what I was supposed to do. Ethically, I've checked the box. But I think you want that sixth model. I think you want to go to five. And I think it's very exciting you looked at this. But you need a model that addresses things that we are frightened to tell people right in the basis of how you get into the discussion in the first place. In other words, they're all somehow we siphon out this is harder and this is harder and this person may not get it and this person just is really a cabbage head. Is that the thing that Bill used? And won't get it. And instead, the kind of respect piece will come from the instinct of the physician that you were talking about to do the traditional giving of information. But at the same time, we've got to have that framed in a way that makes it more useful for more people more of the time. And I think there's some really good indicators here for letting us see where those points are. Because even though those last two categories didn't look like much, together they were almost 20%. So the bad choices still had 20% and pretty consistently across the two. This is really interesting from my perspective. Am I in my time? Okay.